Thank you, Parker. I appreciate it. It's a little unsettling when somebody says that the one and only or something like that. I'm not sure if that's a good thing or not so good thing, but I do appreciate it. Thank God there's lunch, that we have something to look forward to today, so we've got that to do. But we're going to do a little talking. We're going to talk about documentation, coding, compliance. And for those of you that have endured my seminars in the past, we're going to try to break this down and make it interesting. The objective today is to learn how to do this better than we were yesterday, right? So questions are welcome. We don't want you to take over the seminar. That's my job, okay? I get to do most of the talking. But I do want to answer your questions, make sure we're getting everything together and everything down on paper the correct way. So, the other thing I like to start my seminar by saying is my primary job is a chiropractor. I love being a chiropractor. So I'm just like you, thinking about what's going to happen on Monday morning, the patients. I know I've got 2 or 3 new ones on the schedule. I've got reports. We really have a nice busy day on Monday. So I'm excited to get back on Monday. I'm going to enjoy the weekend. And of course, now that football season's back, we've got something to do on the weekend. But I'm very interested in getting back to the office and enjoying it. So that's part of it. 30 years of practice, we want it to be as seamless as possible. And that's part of what we'll be talking about today. So I'll be giving you ideas, maybe hints, some things that we're doing on our office to make it a little bit more seamless, a little bit more efficient as well. Because at the end of the day, what do we get paid for? We get paid for time and services. So we want to maximize those. We want to help as many people as we can. We want to be able to write the story of what we're doing, why we're doing it, where we're doing it. And the good thing is, on the flip side, we get checks. They send us money. They send checks into our checking account for doing these services. And then, of course, the best thing is we help people through chiropractic. So that's where I come from. I love doing it. I love adjusting patients. Guess what I dislike the most in my practice? Documentation, right? I mean, who wants to sit there and do that? I want to have my travel card. My arrows on my travel card were just fine, right? Just like, remember those old days? Some of the older guys do. But those days have long gone. So we're going to figure out how to do it in a 21st century way, in a very efficient way. So let's get started. Some of the beginning slides here, we've got to kind of build the foundation. Got to kind of go through some material, get this foundation built, and then we'll start getting some more interesting things. While all of it's important, we want to get some more practical application stuff for you as well. Okay? Good. All right, so the mission statement. H&S's mission is to make healthcare more accessible, more effective, and more affordable. Sounds good to me. So the objectives of this program are to improve quality of care and treatment outcomes through the use of best practices and superior clinical documentation, and to promote patient safety and reduce malpractice risk. That's pretty simple and straightforward. So there are documentation authorities. By the way, I'm keeping a close eye on you. I'm the president of the licensing board, so if you fall asleep, you stay outside the room, we're going to have your license on Monday. I'm just kidding. I just need to make sure you guys were awake. So, no, not at all. Dr. Sides is the investigator, so we won't have to worry about that today. So there are various authorities on documentation. Number one, H&S has the clinical quality and documentation standards, what are considered best practice standards. The American Chiropractic Association has their own standards, which are consistent with what H&S teaches, and most of that is based in CMS, Medicare Documentation Guidelines. So if you're using these standards of documentation that we'll be talking about, whether it's a H&S patient, a Medicare patient, a Medicaid patient, a cash patient, you're meeting those standards of documentation. Our board has clinical guidelines that give some basic guidelines on various things. Some very specific, some things a little bit more general. But again, if you've never looked through the practice guidelines from the board's website, they're actually on H&S's website as well, you want to do that, so it gives you a good sense of those guidelines. And even Optum has their little black box and how they track things as well. Unless otherwise indicated in this presentation, the clinical record-keeping standards referenced in this program are H&S standards and should not be confused with standards or guides issued by licensing boards or the ACA. So one of the things, I was up in Virginia a couple weeks ago giving a similar presentation, and their Blue Cross Blue Shield is an Anthem Blue Cross Blue Shield up there, and they operate differently. They have a little different corporate medical policy. So there are things that are different state to state. Did we have any South Carolina docs? Because South Carolina has some corporate medical policies that are a little different than here in North Carolina, so we want to make sure we're clear on that. So clinical quality and documentation standards, these are best practices. So H&S has developed best practices which promote the delivery of safe, timely, and effective health care. And these standards are included, you've got them in your handouts here, and if you go to the website, we'll be referring you to the website quite a bit. Staff, how many staff do we have? Quite a few, thank goodness. We're going to learn a lot today. And if you've never spent any time on the H&S website looking at the forms and some of the resources there, put that on your list of things to do when you get back to the office on Monday during lunch, when you got a little downtime, to look through those resources. We'll be talking about a lot of those today. So the clinical quality and documentation standards were developed by the H&S Quality Management and Improvement, the QMI Committee, with guidance from H&S Network physicians serving on the H&S Professional Advisory Boards. So a lot of us have served on those, giving feedback to this and other policies. And they are consistent with industry standards, federal and state laws and policies of the contracted payers as well. And were designed to help ensure your documentation meets the high expectations of all payers, including Medicare. So H&S's best practice establish H&S's performance expectations for contracted healthcare professionals, us. All right, so we're going to break it down. Like I said, we're going to kind of go through, kind of break down things little bit by little bit, initial exams, subsequent exams, and SOAP notes. So bear with me as we set this foundation. The other thing that I would say as you're going through here, it can be overwhelming. So Doc was talking, he was at my Charlotte seminar, God bless you. Okay, so he did this a couple months ago or a month and a half ago, and he's back today. And he's always talking about every time I listen, I learn something new. And if you watch, there's a lot of familiar faces, but you're taking notes. I will do a better job on Monday with my documentation after being in this class today. And I've taught this so many times. But I'm constantly reminded of things that I kind of lose track of, right? You are very good, and then all of a sudden you scratch your head one day and you say, man, we used to do a good job of that. Where did we get off the tracks on that? So I would highlight things, and then as you get back to your office on Monday, just start slowly integrating things into your notes. It doesn't have to be done on Monday, but just start on Monday and get the process. So just kind of highlight those things. Staff, you should be taking notes, adding things that help your doctor do a better job with that and help you collect money and manage patients a little bit better as well. So let's jump into this. So excellent clinical care should be evidenced through excellent documentation in the clinical record. Excellent documentation in the record is essential for sound clinical decision making, which improves quality of care and treatment outcomes and is paramount to appropriate continuity of care. So if you're like me, you want to help every single patient that comes through your office. I expect that when somebody comes into my office for care, I'm going to help them. But let's be honest, we can't help everybody. So rather than taking that patient and extending that care plan to a point where there's no continued progress, you've got to have the documentation, you've got to have standards in your office that help you make that decision. And it happens. We're going to be talking about outcome assessments and that kind of thing. That's what this is really all about, is while we need to satisfy the insurance company, If you take your documentation seriously, it helps you determine medical necessity, making good clinical judgments moving forward. So the lack of appropriate documentation can lead to negative treatment outcomes and potential quality of care and patient safety issues. All right, before we go much further, how many of you are using some kind of electronic note system, EHR system? Nearly everybody in the room. That's fantastic. If I'd have asked that question a year ago, certainly 2 or 3 years ago, it would have been half the room. So with all of these things we'll be talking about, to be able to include all that in your note, it is so helpful to have an EHR. But a good EHR, there's no such thing as a perfect EHR, right? They're only as good as the information you put into it and it gives you back. So we'll talk about that throughout the day as well. But just in general about EHR, software, these programs are very highly recommended. And if electronic records are utilized, there must be appropriate backup and recovery procedures in place. Recovery procedures should be tested at least annually to assure recovery is possible within a reasonable period of time. So this is not difficult. So if you've got a server-based system in your office, this should be part of your compliance plan. Every year, have on your calendar that you're going to test this backup system. So if you have an IT person or you have any 14-year-old in your house that can do this for you, right? Maybe a 12-year-old, to come in there and test that backup. It is so inexpensive to back up all this material. I mean, a terabyte of storage is nothing, it's very inexpensive. So you do it inside, and then I would suggest you're doing it offsite as well. And there are plenty of HIPAA-compliant companies that will do that for you. So that's important. If you're a server-based a cloud-based EHR like I have, then your EHR company should have some kind of documentation that shows the redundancy of the backups and so forth. So you need to have that as well. All right? So complete patient healthcare records, including billing and payment information, such as EOBs, shall be maintained for a minimum of 10 years. Again, if it's electronic, then it's a no-brainer. If it's paper, it does create some difficulties there. You've got to have the storage. Or if the patient is a minor for 10 years after the minor patient reaches age 19. So once the patient reaches 19 and is still under care, the provider should retain the patient healthcare record for 10 years past the final date. If retiring, this is an important one. If retiring, you must ensure patient records are stored in a manner that allows patients to obtain copies, and you must provide written notification to all patients regarding where and how to obtain copies of the records once the practice closes. So a year or so ago, a doctor in the state closed his practice. He boxed everything up and shipped everything to the board examiner's office. Don't do that, okay? Because we will ship them back at your expense. So we don't want you to do that. So again, either lots of young chiropractors, maybe you're not selling your practice, but chiropractors that could take those records, take over those records, take care of your patients, but more importantly is maintaining accessibility to those records. So if you've got a young doctor in the area, that might be a good way to do if you're not selling your practice. Okay? All right. For some of us, we don't think we'll ever retire, so I don't know what will happen with the records. But the basics of clinical record documentation were covered in last year's seminar and included in the H&S Clinical Quality and Documentation Standards. Remember how we used to go through all the little details of things? We'll go through some of that today. But this is the advanced seminar. We've moved on here in North Carolina. So we're going to jump into that clinical care and documentation practice that will help us all improve treatment outcomes and quality of care. So the following are considered essential core standards which promote the quality of care to improve treatment outcomes. Number 1, establish and document the patient's chief complaint. All right, everybody circle chief complaint on their notes. This is the essential. This is the one takeaway that I want to make sure everybody dives into very importantly. Based on the chief complaint and clinical exam findings, establish specific treatment goals for each patient, which are objective, measurable, reasonable, and intended to improve a functional deficit. And to ensure your initial examination includes the use of standardized outcome assessment tools to establish a functional baseline against which progress towards treatment goals can be objectively measured. We're going to talk about treatment plans a lot, but I will say it now and we'll say it again. The easiest way for you to improve treatment outcomes and in your records on Monday is to include outcome assessment tools in it. It's cheap, it's easy, and very effective. So if you are not in staff, if you don't know what an outcome assessment tool is, you'll know by the end of the day, and that's something that you want to make sure that you're using in your practice. Not for 80% of your patients, not for 90% of your patients, but 100% of your patients. So I was at a function out in Denver, and the conversation is a group of chiropractors, and this was a nationally renowned speaker, and it was kind of a smaller group. There were about 12 or 14 of us in the room, and he made the statement, don't you want to have a cash practice so you don't have to do all that documentation? So let me tell you, that's not the case. If you're a cash practice, these same standards of documentation are required of you. So if you were to go into a malpractice situation, these are the standards that you would be held to. So not because they're paying cash or they're Medicare or Medicaid or H&S Blue Cross Blue Shield or Cigna, they're all consistent standards. So make sure you're maintaining that for all your patients. So doing outcome assessment tools on all those patients, it's very important. All right, so reevaluate the patient every 4 weeks or 12 visits, whichever comes first. Very simple to do. And always, always use outcome assessment tools and other objective measures at each exam to measure progress towards treatment goals, the effectiveness of treatment, and the appropriateness of additional care. It really frees you up when you start really using your documentation to make these decisions. So use the comparison of the results of the outcome assessments and other measurable objective findings to determine when MMI has been reached, then release the patient to maintenance or supportive care. So again, get the patients in, get them to a point of MMI stability, and then convert them into supportive care or maintenance patients if so indicated. Again, yeah?
What are your procedures such that when at your front desk, for instance, in the first phone call, how do you know until after you examine your patient really which OA tool you want to use?
Great question. So the question is, when the patient calls in, when do you determine, or what's your system of determining which outcome assessment tools you need? So I do that after I finish my exam. So once we do that, because again, the patient comes in and says, I've got shoulder pain, right? Does this happen? I've got shoulder pain, but this is the shoulder. Oh yeah, it's a little stiff up in the neck, but this is my shoulder. So there's no functional problem. There's really no pain in the shoulder proper. So you're making a decision. If you did a shoulder outcome assessment, then it would be inappropriate. So in my office, once I finish the exam, I have a little sheet. I circle the outcome assessments that I want my staff to have the patient perform, and that's when we do that. Okay? Yeah. Hey, Doc.
Good one. What is it? Because the patients just love these assessments, you know.
They love our paperwork, absolutely.
Try to divide it up and start with something like a functional rating index, which is a general neck and back pain.
Right.
And then afterwards, say, well, I need these x-rays and a compression index and a blood test and whatever else. You're not getting the 5 sheets you fill out.
Sure.
Right to start with.
Right. Yeah, you really need to, to mitigate it. Of course, if you're doing outcome assessments, depending on which one you're doing, 12, 15 questions, maybe 20 questions. But this is the thing, and docs, we were talking about this at breakfast this morning, is this doesn't have to fall solely on your shoulders, docs. This is a simple task that you can get your staff to help you take care of. Other than telling my staff which outcome assessments I need, and me interpreting the results, my staff handles all of the effort to get those filled out. So outcome assessment tools are done 100% of the time in my office with every patient. Not 95, not 99, 100% of the time. So we were not doing that well in our office, and so we came to the point where I said, I will not see a patient unless the outcome assessment tools are done for that report of findings on that second visit. So they're doing them, whether they're doing in the office, we have the capability of emailing them to the patient, and the patient goes through the portal and does that. I don't care how you do it, as long as they do it, but I will not see the patient till they finish their paperwork. So, again, when you start setting this standard, so guess what? When I set that standard, we rose to that standard, so it happens all the time now. So I find it more difficult when you have flare-ups and aggravations to keep on top of that. So again, we have procedures in our office. If I forget to tell my staff which outcome assessment tool we need to use, my staff is expecting that we'll do that, so automatically they're going to ask me for that. So I have a backup with my staff. New patients, process them is a little bit easier. But the bottom line is getting those into your office. And this is the crazy thing. It's free. It doesn't cost you anything to have other than the paper that it's printed on, to get these outcome assessments done in your office. Okay? I had one doc, he didn't want to go through the paper, so he went in and took all of his outcome assessments. He had them laminated, and so the patient will sit down with a laminated oswestry and go through and do that, and once that's been entered, then they erase that. I don't care how you do it, just do it, all right? It's good. I like that. Very green, very green. So once that MMI has been reached, then release the patient to maintenance and supportive care. Again, we're not trying, these are not insurance patients. Blue Cross Blue Shield doesn't dictate what we do to our patients once we get to this MMI point, and then we take the patient and we can provide the services that we think best fits them. All right? So other core standards: ensure all diagnoses, all services provided, and the rationale for those services and all treatment recommendations are properly documented in the healthcare record. Ensure that all treatment billed to payers is consistent with the chief complaint, objective clinical findings, diagnoses, and payer corporate medical policies. You with me on that? Chief complaint, spend the time, make sure you know everything that's wrong in that chief complaint. That's why I had you circle that, because everything starts there. That's the beginning of the sentence, beginning of the story, and then everything else comes away from what is happening in the patient's chief complaint. So again, what happens, docs? Again, I'm in the office like you are. We go on the patient, they've got shoulder pain, right? I've got shoulder pain. You realize it's not shoulder pain, it's neck pain, and then they've got some interscapular pain in the back. And you go in, you do your exam. As you are walking out the door, you grab that and you say, I'll see you tomorrow. They say, oh, one last thing, right? One last thing. I get this little catch here in my hip, right? And it's the SI joint, they call it the hip. So what happens at that? They've messed up your mojo, haven't they? So you're walking out the door, crap, these patients, they're such an inconvenience to what I'm doing here, right? So you stop, you turn around, okay, tell me about that catch in your hip. That's another chief complaint. Add that to that. Go ahead and go through, ask the right questions, go through your examination, determine if you need to add some x-rays. Again, what do we get paid for? Time and services. So now you're doing the proper things, the patient's coming into you, you're taking the time to do that. Don't wait till the next day to do that. Finish up that exam. Make sure you scope out all of those chief complaints and get that taken care of. Hey, Doc.
So if they say I have shoulder pain reporting here,
Yeah.
when you're documenting it, do you say patient complaints of shoulder pain? And you justify it?
Yes. So yeah, because the patient's typically going to, when they fill out their history or your initial paperwork, they're going to put shoulder pain. And then you go through and explain, patient is having muscle spasms in the upper trapezius area, extending up to the cervical spine and down into the shoulder. And you just describe what it is. And then, of course, objectively, you're going to go ahead and do a shoulder exam on that patient. You're going to find full ranges of motion, negative orthopedic test, but all positive tests for the cervical spine. So that's a good point. So if they come in and they say shoulder, how does that's not congruent with the exam and your diagnosis and all that stuff. You just clean all that up through your exam, okay? So again, just making sure you're finishing that up as the patient adds that layer, or the worst is 2 or 3 visits in, and I say this facetiously, is they say, oh, you guys take care of the migraines, right? You take care of the migraines, and yeah, we do. We have good success with the migraines. But then you've got to stop. Again, that's not the first day, because we like to stay in our box, don't we? But now we're 2, 3, 4 visits in. They saw the brochure out in the waiting room about migraines. And they want you to start doing migraines. So what do? You take the time, you do the assessment, you update your diagnosis, you do your exam. If you need to take cervical films on that day, go ahead and take cervical films. Blue Cross Blue Shield isn't come knocking at your door because you took cervical films 3 days or 4 days after the initial day that you took low back films on, because there's a new chief complaint. That's the way it is. So you manage that patient, but you've got to jump through all those hoops to make sure it's done properly. All right?